Вітаю, шановні колеги в Україні. Ми раді зустрітись на черговій серії вебінарів «Україна-ЄС про спінальні дисрафізми». З приємністю хочу нагадати, що організаторами цієї серії виступає ERN ITHACA, Міжнародний благодійний фонд «OMNI-мережа Україна» та Міжнародна федерація Spina Bifida та Hydrocephalus. Також нагадую деякі наші правила. Кожен, хто відвідує наш вебінар онлайн, може отримати сертифікат участі. Також учасники мають можливість отримати 1 бал міжнародної акредитації, заповнивши опитування після закінчення вебінару. Ті, хто пройшов опитування, отримують сертифікат з міжнародним балом за 3 тижні після вебінару. Є ще досить специфічна інформація для українських учасників. У разі повітряної тривоги просимо вас негайно перейти в укриття. Перегляд запису вебінару та відповіді на питання будуть доступні згодом. Традиційно ми розпочинаємо наші вебінари із реакції на попередній вебінар, із відповідей на питання. Тому я запрошую зараз до слова модератора наших вебінарів, професора Giovanni Mosiello. And now I welcome my co-moderator, Professor Mosiello.
Dear all, welcome to this new webinar on spinal dysraphism. I'm Giovanni Mosiello, and the webinar of today is focused on physical rehabilitation on spina bifida patients, point to know, presented by Gessica Della Bella from the Spina Bifida Center in Rome and Dr. Leonard from the Spina Bifida Center in Dublin, Ireland. On behalf of ERN ITHACA, International Federation of Spina Bifida, and OMNI-NET Ukraine, welcome. First of the webinar, we would like to answer to the question of the previous webinar held by Dr. Michael Maternick in kidney function in myelomeningocele children. We received some questions. The first question was, what indication for kidney function are indication for kidney removal? Hypertension responding to medical treatment, reflux and hydronephrosis with recurrent UTI. If you decide to perform nephrectomy for the above indication, consider to preserve the ureter. That could be useful for a derivation if required, instead of appendix. Second question was related how to determine the glomerular filtration rate. What to use, Schwartz formula or using creatinine and cystatin C. The cystatin C is the best solution if available. Otherwise, creatinine. Schwartz formula is not very useful in this kind of patients. Other question was related to arterial hypertension and the percentage of risk and the resistance to the treatment. The percentage are different between ages, increasing in older children due to increased weight and renal scars. Up to 10% of patients present hypertension. Anyway, a correct follow-up and prompt management mostly avoid complication. Low adherence to treatment is common in low chronic situation in adolescents, but in spina bifida is mostly related to clean intermittent catheterization. Last question was about the connection between spina bifida and diabetes mellitus. There is not a clear connection with the type 1. On the other hand, obesity that is common in these patients and is a risk factor for type 2 must be considered. I hope really that you will enjoy the webinar of today. As usual, you can do your question during the webinar or later, sending on the website, and enjoy the webinar. Thanks for your participation.
I'm sorry. I'm sorry. Thank you very much, Professor Mosiello. And now I give floor to our esteemed speakers and Professor Gessica Della Bella, please.
I'm going to speak about spina bifida physical rehabilitation points to. Before to start my presentation, I would like to remind you two concepts on the physical rehabilitation medicine that we can define as the medical specialty that uses rehabilitation as core health strategy, and then health condition. We can define it as a state of complete physical, mental, social well-being, and not merely just absence of disease. Each year, about 1,427 babies are born with spina bifida. We know that Hispanic women have the highest rate of having a child affected by spina bifida. We know that also the spina bifida represents a significant cause of chronic disability. We can have, in fact, motor sensory dysfunctions associated with neurogenic lesions. We can have bowel bladder dysfunctions. We can have central nervous system disorders accompanied by the hydrocephalus. But we have to know at this point that all these issues are associated to different degrees with limitations in both activities, mobility, self-care, cognitive function, and participation, employment, social integration. We have to evaluate in team. We need to multidisciplinary team and interdisciplinary team. In our hospital, we usually we prescribe and perform optimal patient-centered rehabilitation program within multi-professional team working in the interdisciplinary fashion for individual with spina bifida. This slide shows you the model used from us in our unit. In this slide, I show you this article. It's very, very interesting because evaluate the importance of multidisciplinary management of with OSD and specific needs for different age. In for specific needs, we involve specific physician, specific specialist for doing evaluation in team, in multi and interdisciplinary. I think that this plan is very useful for us for assessment of this patient. In this other paper, it was evaluated the roles of PM physician in management in patients with spinal dysraphism. We know that the role of physical rehabilitation medicine physician is to treat the whole person in order to improve quality of life, but don't only. The physical rehabilitation specialist to evaluate the whole person in order to improve the function. So he needs to multidisciplinary setting and needs to follow up individuals with the spina bifida. He has to take in consideration the general health conditions of this patient, because we know these patients can have different comorbidities. And finally, this will enable timely recognition of early deterioration and subclinical or clinical changes. But in physical rehabilitation medicine, the physician, for example, physiatrists, have to perform a complete functional assessment, including activities and participation with special attention to the presence of specific impairments. such as deformities of musculoskeletal system, bladder bowel dysfunction. But we can do it if we use ICF. We need use ICF to do it, to reach this assessment. In particular, we have to use ICF of function, ICF disability and health for children and youth, ICFC. But we don't have to forget the importance of outcome measures. For spina bifida, we have specific instruments, and for example, for a quality of life, we can use the questionnaire for children and for family, and we have to use it too. As I told before, a spina bifida is a complex deformity. We can have deformities of spine, we can have dislocation, fractures, with deformities. I would like to start from this paper on importance of mobility. And this is the guideline on mobility for care of people with spina bifida. We all know the mobility is a fundamental learning experience for the children. But we know at the same time that is not possible for all children. We know also that we can have different lesion level in this population of patients, from thoracic to sacral, so that we can have different motor impairments, motor difficulties. In our work, we have to focus on this topic, mobility. We have to know the benefits of mobility on contracture management, bone density, bowel bladder evacuation, pressure reduction, improve underlying pain, reduce stress, to know it. But we know also that in majority of cases, the patients need to use orthosis and or wheelchair assistance to enable locomotion. In the first case that I present to you, we have the child with lesion level on lumbar, mid-lumbar, and he is able to move the wheelchair. He is able to stand with upper support, with the brace and with the orthosis. He's able to move with the walker. He is able to move. He can feel this sensation, good sensation. We don't forget it. In this slide, I present you this orthosis. It's not so easy to address, but it's most useful for some children with spina bifida. We can consider it as instrument to training, to walk at home in a safe place. It's not so easy, but it's useful for children because he is able to live a good and good sensation, and the sensation to move, to gait. I present you another case. She's a little girl. She's very, very nice, very smart. She wanted to, she wanted independence, but she has very, very contracted muscle. So we decided together with the interdisciplinary team to give her the possibility to stand, to stretch the muscle, and to move. So in this modality, we give her the promote independence at home, at school, and she was very happy to use it. In this third case, she's quadriplegia and severe scoliosis. She just the brace. She has the left hip subdislocation, and we decide to use the standard with hip abduction to prevent worsening of hip dislocation, and also to favorite the different position. The last case, we have a child with clinical complex, and she has had 4 fractures and 4 times different for osteoporosis. He was has had deformity, foot deformities, but he asked every day to parents to want to work. I would like to work, Mom. I would like to work, Dad. So we tried in different steps, different workers, and finally we decided for this one. He was very, very happy to leave this sensation to the. She feel now is very, very happy to leave the sensation to get to move. So we can pass now to other deformity, and we know the prevalent deformity of spinal scoliosis. Is one of the most common severe orthopedic condition patient with a spinal bifida. We have to say that the variable effects that scoliosis can have on an individual, the comorbidities associated with the progressive scoliosis and the risk associated with the spinal surgery call for a strong partnership and care coordination between medical, for example, physiatrists, and surgical orthopedics teams to deliver a patient-centered approach. We don't forget this. It's important to work together to cover in the same time the evaluation of patients. And quickly, I show you this article because I found this very interesting regarding the relationship between different issues. Motor function, cognition, independence, and quality of life. Of course, we know that motor function was strongly related to mobility and lesion level. But regard the rehabilitation program, we have to advance the technology. In last 20 years, we have we saw different robotic system to improve the function, to improve to permit the gait, to favorite the standard and the gait with device. So I show you in particular this robotic system for children as very useful for children with motor disability, but for children with a spina bifida too. This is a test in our hospital. We have not yet this robotic system. I find this robotic system is very, very useful for training, for favorite to children to live different experience and the fundamental experience, as told before, the mobility to gait. This is our patients in other center of rehabilitation. He tried to walk to gait with this, and he was very happy to try it. But we can see this this time that in this point the importance of advanced technologies. We all know the importance of the advanced technology, the robotic system, device, but we have to focus on sport activity. The sport activity, the adaptive physical activity is very important for children, for adults too, with motor impairments and intellectual impairments, for children with disabilities. Because I believe that the physical activity is useful for reach the well-being condition, so health condition. And with the rehabilitation program, we can improve function. We can improve function, but also with the sport activity, we can improve function. But overall, we improve the mental health condition. I believe that in the process of rehabilitation program of the patient is important integrated with sport. The children need to sport, need to live this experience. In the article that I show you is reported the importance of physical activity levels. It's not only in weekend day, but every day, from Monday to Sunday, not only in weekend. And the other points fundamental is the importance of individually tailored assessment and intervention. It's very important to build the specific project, rehabilitation project on specific patient tailored. It was done ad hoc. But I would like to thank Dr. Giovanni Mosiello. He is very important for our group and our multidisciplinary team, as you can see in this slide. I would like to thank to staff, to ITHACA, and to invite me to speak of Spina Bifida rehabilitation medicine. Thank you so much for your attention.
Good evening. My name is Leonard. I'm a paediatrician in neurodisability based in Dublin in Ireland, and I'd like to thank you for the opportunity for having me share our management of children with spina bifida from our service here. I thought it would be helpful just to remind a little about the physiology of spina bifida. On the left-hand side of the screen, we can see a typically developing brain and spine. And here you can see what happens in spina bifida. Spina bifida is a failure of the neural tube to close early in fetal life. The degree to which a child is affected by this will depend on whether the skin covers the affected area or not. We can have closed defects where the nerves and skeletal structures around the nerves are affected but not exposed. That's in a closed neural tube defect. And in an open defect, you have it when the nerves are exposed. These two different types of spina bifida have varying clinical needs. So the open myelomeningocele, and that's going to be the main focus of my presentation. The closed dysraphism is a child who's more able from a motor point of view. And for that reason, because the two sets of children have very different clinical needs, we have two different clinics in our hospital. So a closed dysraphism clinic and a myelomeningocele clinic. So moving back to the myelomeningocele, as you can see, the skin is broken. So the nerves aren't covered and are exposed to amniotic fluids. This chemical irritant effect, even though the amniotic fluid is sterile, leads to permanent damage of the nerves, and hence you'll have the paralysis and the issues with sensation that you see in myelomeningocele. This happens distal to the lesion, so from the level of the lesion down. Another thing that happens because the nerves are exposed is there's constant leak of CSF from the lesion. So if you look up a little bit higher, with laws of physics, there's a pull on liquid, and what actually happens is the hindbrain and cerebellum are pulled downwards. So this is called the Arnold-Chiari malformation. This is very problematic when this happens. This leads to obstructive hydrocephalus. As you can see, the normal channels of CSF here that are open are blocked. This leads to obstructive hydrocephalus, which has its range of issues in terms of impact on the brain, and also brainstem dysfunction, which leads to issues from a respiratory point of view and a swallowing point of view. It's important also to remember that the neural tube defect affects it's neuroectodermal, affecting the whole neural tube. So it's not just the spine. The brain is also affected. So the brain of children with spina bifida is also different to a typically developing child. There's abnormal architecture, issues from a cortical and gyral perspective also. We have 500 children with spina bifida in Ireland, and attending our open myelomeningocele clinic in Dublin, we have over 260 children. That's the service that I'm going to describe to you and the medical complications that we encounter. As you can see, there are many different health impacts from spina bifida, ranging from tissue viability, which we'll discuss, obesity, congenital scoliosis, issues with vision and renal function. Some of these I know will be covered by my colleagues in the session. As with any child from a disability perspective, the goals are similar. The goals for us, for our patients, is that each individual with spina bifida will experience a satisfying and productive life, independently functioning and healthy. So there's two areas where we aim to meet this goal. One is to address the medical needs, so the primary medical needs, and avoid any secondary disability. When we talk about the primary medical needs, we're talking about lifelong, comprehensive medical surveillance and input. So in our clinic, there are 4 disciplines involved: neurosurgery and urology, and you'll have heard from those counterparts already today. There's musculoskeletal in our clinic that comprises an orthopedic surgeon and a physiotherapist, and then general neurodisability, which is myself and the nurse specialist looking at the general health issues, musculoskeletal issues linking very nicely with physical rehab. In terms of avoiding secondary disability, so the primary disability of the nerve damage, that's something that we cannot fix. However, with knowledge of potential complications that can occur, we can avoid secondary disability. And that's where it's important to anticipate complications that may arise and work around them to prevent them. We do this in shared care with the local teams also. Examples of issues that we might anticipate would be pressure sores, which can be avoided, obesity, which we can look at trying to address, and bone fractures. We will talk more about all of those shortly. I wanted to highlight a really helpful set of guidelines that have been drafted by the Spina Bifida Association, that's SBAA in the United States. This is the most recent copy of the guidelines, which were devised in 2018. It's the 4th edition. And they go through all the different subsections and areas of health of a child and adult with spina bifida, with recommendations of best practice. I'd like to speak first regarding motor function. Tied along with motor function are orthopedic issues, and there can be congenital orthopedic anomalies in association with spina bifida. That would include clubfoot or talipes from the child who is not moving so much in utero. There could also be scoliosis, kyphosis, and hip dislocation. Kyphosis is something that needs to be monitored and addressed conservatively where possible. Occasionally, surgical intervention may be necessary, and also in scoliosis. Hip dislocation practice would dictate that surgery would not be necessary for the non-ambulant children from a functional perspective. I'd like to draw your attention to the different levels here. I'd said earlier that severity depends on the level of the lesion, and that's certainly the case in functional mobility. If you imagine children with a lower sacral lesion, where it's S1 and S2 are the nerve roots affected, these children will ambulate independently and present a very different clinical picture to the children who have lesions more proximally. For example, in a thoracic level, these children are the most affected from a physical point of view and are non-ambulant. The nerve root L3 is kind of a cut-off in that if your functional mobility level is below L3, it will be possible to ambulate independently. If it is above L3, it will be difficult for a child to be independently mobile. Obesity is a particular issue in the non-mobile cohort, and in general, the medical complications are much more severe in the non-mobile cohort. In terms of designing a clinic, it can be helpful to have the more involved children all together in one clinic, and the children who are less involved together also, as they will have slightly different needs. So given limited mobility in the non-ambulant population, their caloric intake often exceeds their caloric requirements, and therefore these children are at risk of obesity. We are aware there is a vast array of secondary health complications associated with obesity, for example, diabetes or or high blood pressure, it's really important to try and get in proactively and prevent this early. In the non-ambulant children, your body mass index isn't very helpful, as it can often be very difficult to accurately measure the length of children sitting in wheelchairs. What we have found that measuring the mid-upper arm circumference is very helpful, and we have special measuring tapes that we can share with you, which give a traffic light system in terms of when it's important to be concerned regarding nutrition and when to refer to dietetics. So that's the mid-upper arm circumference. A word to go back just a little bit regarding obesity. How do we try to prevent it? Well, very early on in the clinic, we talk to parents about small portion sizes, avoiding avoiding sweet treats, giving non-sweet treats, and embracing a healthy attitude to dietary intake in the family. It should be the whole family, so that the child with spina bifida does not feel excluded. But really trying to get those good eating habits in early on to avoid excess weight gain, as once the weight is there, it's difficult to lose it. So that's our approach in terms of prevention. We talked about tissue viability. So as you are aware, children will lack feeling distal to the level of the lesion. Because they lack feeling, they are lack sensation, they are at risk of pressure and temperature changes. Should they ever get pressure areas, for example, from an ill-fitting splint, it can be quite difficult if the skin breaks down for the pressure to heal. This is because the nerves and blood vessels travel together, and as well as having poor sensation, there is poor circulation and subsequent poor healing. So therefore, you're certainly trying to prevent pressure areas as opposed to trying to treat them. How can they be prevented? Children can have pressure relieving cushions on their wheelchairs. It's important to educate parents regarding regular inspection, for example, the site of the orthoses. So the splints that the child is wearing, the child won't feel them. So it's important to look for red areas, and if it looks like there's pressure, then they would need to be refitted. It's important for children and young adults to learn to inspect pressure areas, and that can be done with the help of mirrors sometimes. It's important to have good nutrition in terms of any healing of pressure areas, and advice regarding avoiding tightly fitting clothes. It's important to seek care early if there's a pressure area to avoid it becoming more complex, and worst of all, avoid it becoming infected, as that can lead to a child becoming very unwell. As with any non-ambulant children, it's important to be aware of bone health. Our bones strengthen due to forces of gravity when we are on our feet. Therefore, non-ambulant children are at risk of osteopenia and may have fractures. Some of the fractures may even be unexplained. In terms of promoting bone health, it's important to have a good amount of vitamin D. We check levels and give 400 units when the levels are satisfactory. If the vitamin D levels are low, we give 800 units. It's important to have calcium in the diet, a good source of calcium, and also using standards in the non-ambulant can be helpful from a bone health perspective. It's important that all care providers understand that the non-ambulant children with spina bifida are at increased risk of fractures, and to manage sensitively should one arise. In paediatrics, if a fracture is unexplained, we often that would raise a concern regarding non-accidental injury. So it's important to be aware of the risk in our population and manage this sensitively. The next topic is sleep disordered breathing. So sleep disordered breathing is when there's an impact in particular on the lower cranial nerves and the brainstem, as you're aware from the Chiari malformation that was referred to early on in the presentation. There can be an impact at brainstem level in association with the Chiari malformation. This can lead to sleep disordered breathing because it's necessary to have integrity of your respiratory circuits, and this can be problematic in the population with the Chiari malformation. It's important to be aware of sleep disorder breathing because if it is an issue, it can affect growth and cognition and quality of life. How may you be aware of sleep disorder breathing? It's important to screen for it in the clinical review, asking parents regarding noisy breathing, pauses in breathing, or often daytime somnolence. If these symptoms are prevalent, they can be referred to our respiratory team, who may organise a sleep study, and occasionally respiratory support overnight may be of benefit. Sleep disorder breathing is quite prevalent in our population and under-recognised, so it's important to look for it so that it can be treated. Children with hydrocephalus are at increased risk of seizures if there's raised intracranial pressure, as there might be with a shunt blockage. As I said earlier, the brain structure in a child with spina bifida is different to a typical developing child. So because of heterotopias and different cortical abnormalities, the child with spina bifida may also have epilepsy. This can also be associated with learning episodes, with learning disability, I apologise. And sometimes there are staring episodes which may not be epileptic. So these are issues that may present in clinic. Any epilepsy in spina bifida tends to have a good prognosis and responds well to medication. Finally, I wanted to highlight that occasionally there is precocious puberty in association with hydrocephalus. This is due to premature activation of the hypothalamus pituitary gonadal axis. We see this more often in girls. Why is this relevant? It may limit final adult height, but more importantly can cause psychological distress and an increased burden early on for the carer. It is possible to delay puberty somewhat with medication. So if it is recognised, GnRH analogues can be used for several years to delay the onset. This is our centre. We work at the Children's Hospital in Temple Street in Dublin. And this is the building. We're amalgamating 3 paediatric centres in Dublin. And this is a children's hospital that we hope to move to next year. In terms of our multidisciplinary team managing the cohort of spina bifida, there's myself and the nurse specialist. And as mentioned earlier, we have a urologist, a neurosurgeon, and orthopaedic surgeon. Other team members are physiotherapy, occupational therapy, social work, neuropsychology, clinical psychology, and we have admin support and a coordinator. So we started quite small, but our team has developed over the 13 years that I've been in post. In terms of how we run the service is more of an outpatient service. Inpatients would really be the newborn babies and the neonatal spell. In terms of the neonatal surgeries and education can tend to last several weeks. So that's quite a busy time for the family. Subsequent inpatient stays would be elective, possibly for a urological procedure or orthopedics, or they can be emergency in terms of a shunt blockage. Antenatal counselling takes place when children are identified, when the mom is pregnant, and this can be very helpful to meet the parents, to explain what they might expect of a child with spina bifida. It can make the neonatal phase easier when there is greater understanding. Children with spina bifida have an annual review in our national centre from the age of 1 to 16 years. Share is cared with our local team, also nearer to home. As mentioned, these are the disciplines that are present at clinic, and our spina bifida team meets every week to talk about all the inpatients and outpatients where issues have arisen. So that's a multidisciplinary approach. I talked about shared care with the local team, so there's access to local physiotherapy and occupational therapy at local level. That can sometimes be difficult to access. There is access to a local paediatrician and GP. As in many other countries, adult care can be more fragmented and difficult. This is something that we hope to develop and a pathway for our adults with spina bifida. We see 10 children per clinic, and we do 26 clinics per year, which are half a day. The clinical staff tend to see the children separately, and we liaise with each other during the clinic, and that's felt to be the best use of time of the individual clinicians. We review and liaise with the local team or parent in advance of the appointment. We set goals at clinic, and we have a great focus on independence, as this is really important for the young person with spina bifida, and we plan transition to the subspecialty services. We feed back to the local team following our clinic appointment by letter. So myelomeningocele is medically complex, and it's important to anticipate complications that may arise and hopefully prevent some of them or address and treat in a timely manner. The multidisciplinary team approach, working together, will lead to best outcomes. We share all our decisions with the children and family, and overall aim for a holistic approach, considering social aspects and education also. I'd like to thank you for your time, and I'd be really delighted to address any questions. Thank you.
Thank you, dear Dr. Jane Leonard. Шановні колеги, аж не віриться, що позаду 9 вебінарів, на яких ми намагалися розглянути максимально повно проблеми, з якими штовхуються, складний спектр проблем, з якими штовхуються пацієнти із спіна біфіда. Звичайно, зробивши акцент на проблемі, яка, очевидно, обумовлює і тривалість, і якість життя наших пацієнтів. Це проблеми, це урологічні проблеми і нефрологічні проблеми пацієнтів із спіна біфіда. Я думаю, що ви підтримаєте мене в тому, що це обговорення було досить цікавим, актуальним, живим і надзвичайно корисним для нас. On behalf of all Ukrainian participants, I am honored to express our common opinion to our thanks to the organizers and our esteemed speakers for their active participation, lovely discussions, their professionalism, sharing their experience, and for extremely interesting, useful, and up-to-date information. And all of this even more important in our current situation, when our children suffer and fight double war for survival. Ukraine and Ukrainian children need your support. We welcome your help and partnership. Now it's my pleasure to invite our co-organizer, Dr. Silvia Rosen, from International Federation for Spina Bifida and Hydrocephalus. Dr. Rosen, please join us.
Thank you so much, Dr. Zymak, and it was a real pleasure. And of course, we had excellent speakers. And Jane, Jessica, thank you so much, because I think both your presentations showed really well the need for multidisciplinary care. And while it seems we do not have questions in the chat, maybe I can reflect a little bit on this series while maybe the questions still come in. We started last year in November, and we covered really different topics, from epidemiology to etiology, neurological aspects, neurogenic bladder, kidney functioning, to rehabilitation, as we're sitting here today. But it truly takes a multidisciplinary team, as we are sitting also here with the different partners. And it's a pleasure that we were able to organize these webinars together with OMNI-NET Ukraine, Dr. Zymak, the ERN ITHACA, ERN EUROGEN, and as International Federation, I personally also found it very stimulating as a process of knowledge exchange between both the European partners and colleagues and the Ukrainian colleagues. And this meeting sparked also interest for more, as we could see by the many questions that were coming in for each meeting. And not only, I think, going forward, it is about finding ways to further optimize better practices, but more importantly, the work that you do, that we all do together, it strengthens the quality of life and the independent living of persons living with spina bifida, as well as the families. And that's what we are looking for, and that's why we are working so well together in partnerships. And on that note, maybe I can first give the floor back to Dr. Zymak, because I see questions coming in, and then maybe thereafter our coordinating partner has also some ideas from the perspective of EUROGEN and EU and Ukraine possibilities in the future. I look forward to that. Dr. Zymak, I give the word first back to you.
We have some troubles with sound. I suggest we give answers later, maybe.
No, or maybe in the chat. I don't know if the speakers can see the question in the chat. And by the way, very good questions about economy. So for sure we will need an answer on that. But yeah, what about perspectives? How can we continue, and how can we collaborate more?
У нас завжди залишається перспектива отримати ці відповіді в постчаті. Back to you, Dr. Rosen.
Thank you so much. Yeah, then I will give the word to Michelle as the coordinating representative here of EUROGEN to share some thoughts about the EU-Ukraine collaboration and partnerships.
Thank you. Yes, I'm Michelle Batty and I'm representing ERN EUROGEN. Firstly, I think we just have to acknowledge and say the absolutely heroic efforts that have been made by the Dr. Zymak, all her colleagues, OMNI-NET colleagues, with it working under unspeakably awful conditions within the Ukraine. So, you know, this collaboration wouldn't have been possible without enormous dedication and courage, I think, from you. So we're really thankful for that. And it really is a new world of collaboration. We have the European reference networks really working closely with patient organisations in a way that's never been seen before. And I would like to really thank the European Commission for funding and organising this collaboration. Without their enormous financial and strategic support, none of this would be possible. So I would like to thank them as well. So reflecting on our collaboration, we've had a great start to it with the webinar series. It's an educational webinar series, and we're driving at the heart of what the ERNs are here for, which is knowledge sharing. And that's much easily able to be done in this virtual world. And that's fitted in quite well in all the conflict situations. So we're really able to get help over to Ukrainian clinicians as quickly and easily as possible. So the collaboration started with this really successful webinar series, which is closing now. And we will have another one which will start in the autumn. So we really look forward to that. And also, I'm delighted to announce, so EUROGEN has signed its grant agreement, its financial agreement with the European Commission. And we're really pleased to announce that we've included 2 specific work packages all about collaboration with the Ukraine. One of those will be educational activities, the continuing of the webinar program. And then also we have a tool, we have an IT tool that's kindly provided by the European Commission. It allows for safe and secure virtual consultations. So in the autumn, when the new version of the tool is available, it's called the Clinical Patient Management System. It's fully safe and secure, so no medical information can be leaked in any way. It's very safe for the patients and doctors to use. So we will be able to give virtual clinical advice to Ukrainian colleagues on any of their tricky cases. So that will be fast, it will be secure, and all the network's experts will be able to freely share their advice. So that will really intensify our collaboration. So thank you so much, and we really look forward to seeing what we can do in the future. Ah, we have Giovanni.
Yeah.
I'd like to hand over to him the floor.
Michelle, thank you very much for all, and thanks to all. Just to say thank to you everyone for your great collaboration. I am here for the European Congress of Pediatric Urology. Today we have talked about you with Professor Fates, Raimo Stein, Rafal Sharzan, Giovanni Montini, and Professor Reid Nyman, Chris Radmeyer, all the speakers of the previous session. And we are working for the next session. As you announced, Michelle, we would like to continue with this great family. I meet some colleagues that participated, that have the opportunity to participate to this webinar, and all of them would like to continue. So a great thanks, first of all, to Darren that supported to us for all this time, and it was very precious. And without him, I believe that it was impossible to have this wonderful series. Thanks to OMNI-NET, to Dr. Zymak, and thanks to Sylvia for Ruth and for the International Federation of Spina Bifida. Thanks to Michelle and all the staff of EUROGEN, that was precious, and also the other ERN that participated, and ERN ITHACA and ITHACA. And thanks, of course, to the speaker of today, Gessica and Jane. And thanks to all. And for me, it was a fantastic experience, and I would like to continue. And I hope to have all of you for the next year with the new series. We come back. I suppose that you announced that we have an extra meeting to present the new series, and we will come back to you. Thanks again. Bye.
Дякуємо нашим прекрасним спікерам, дякуємо професору Мосієлу, який перерахував всіх учасників наших вебінарів, наших прекрасних спікерів, які зараз працюють на Європейському конгресі дитячих урологів, знову ж таки продовжують. І дякую пані Мішель Баті, яка висловила надію і сподівання, що наша співпраця буде мати активне продовження, і вона стосуватиметься у подальшому навчання, а також можливості безпечного телеконсультування пацієнтів, наших пацієнтів із нашими колегами у Європі. І це прекрасно. Thank you very much for all great team.
Thank you, and looking forward to seeing each other soon.
Yeah. See you
Take
soon
care.
during new series of webinars.
Absolutely.
Autumn.
Goodbye, everyone. Thank you.